Hyponatremia is another potentially life-threatening electrolyte imbalance that puts clients at risk for brain injury and fluid volume disturbances. Hyponatremia is defined as a serum sodium less than 135 milliequivalents per liter. A serum sodium under 120 milliequivalents per liter is considered severe hyponatremia. As serum sodium drops, the osmolality of the bloodstream also decreases. The fluid shift in hyponatremia is the opposite of the shift observed with hypernatremia. Fluid will always move towards the compartment where the solute concentration is the greatest. Within hyponatremia, the solute concentration is lowest in the bloodstream and higher inside the cells. So fluid moves into the cells, causing the cells to swell. Remember, brain tissue is very sensitive to high and low serum sodium concentrations, but their pathologies are very different. What are 3 common causes of hyponatremia? Hyponatremia is caused by a total body water loss that is proportionately lower than the sodium loss. Hyponatremia is also caused by an increase in total body water that is not accompanied by an increase in sodium. This is the most common cause. Hyponatremia develops from an increased secretion of ADH. This phenomenon is observed with SIADH, that's syndrome of inappropriate antidiuretic hormone secretion. Hyponatremia is also caused by a decrease in dietary intake of sodium or an excess of sodium excretion. The factors that place a client at major risk for the development of hyponatremia include excessive oral water intake, which increases total body water, excessive use of hypotonic IV solutions, deficient dietary intake of sodium, vomiting and diarrhea because they increase sodium excretion, nasogastric suctioning because it increases sodium elimination, and diuretics because sodium is lost in larger concentrations than water is. Certain diseases also place the client at risk, such as chronic renal insufficiency due to increased total body water, adrenal insufficiency due to sodium loss in greater amounts than water, SIADH due to increased total body water related to increased ADH, congestive heart failure due to fluid volume overload, and disorders that redistribute sodium to the third space, such as ascites. The signs and symptoms of hyponatremia are generalized, nonspecific, and can indicate many other disorders. They include confusion, headache, lethargy, stupor, coma, seizures, anorexia, nausea, vomiting, abdominal cramping, muscle cramps, and muscle twitching. Diagnosis is primarily based on the serum sodium concentration and the client's signs and symptoms. Other helpful lab tests include urine osmolality, serum osmolality, and urine sodium concentration. Management is driven by the etiology and the severity of the hyponatremia. Caution must be used for all clients during the process, as treatment that is too aggressive can result in pulmonary edema as fluid is pulled from the intracellular space into the intravascular space. The interventions listed here are commonly used to correct hyponatremia and are administered minimally over 24 hours. They are hypertonic sodium chloride solution IV, such as 3% sodium chloride, isotonic sodium chloride solution IV, that's 0.9% sodium chloride, or lactated ringers. Remember, normal saline and lactated ringers are hypertonic for a client who is hyponatremic. Oral intake of a sodium-rich diet, oral fluid restriction, diuretics, hemodialysis, and select drugs to inhibit ADH, such as dimeclocycline, trade name declamycin, and lithium. How can hyponatremia be prevented? Here are some helpful measures. Monitor the client for excesses in oral water intake. Monitor serum sodium, body weight, and intake and output daily. Assess for deficits in dietary sodium intake. Assess and document the client's baseline neurovascular status so that early hyponatremia can be recognized and treated. Modify the plan of care to address coexisting risk factors for hyponatremia. Hyponatremia is a life-threatening disorder that can result in permanent brain damage when undiagnosed and treated. Client safety depends on the comprehensive use of the nursing process and early intervention.